Going to present my case on inert vegetative intraocular foreign body of 10 years duration. There are no conflicts of interest or financial disclosures. Ocular trauma is more prevalent in children, with vegetative matter like wood being the most common. Retained foreign bodies may cause significant visual and anatomical disturbances depending upon the nature and site, and removal within 24 hours is recommended if accessible. So a 13-year-old male presented to our OPD with complaints of sudden painless diminution of vision in the right eye for the past 10 days. There was a history of seeing flashes of light. There was no history of recent trauma or surgery. There was a history of trauma to the right eye with a wooden object 10 years ago, for which the patient underwent corneal tear repair, followed by cataract surgery with PCL implantation. So on ocular examination, the uncorrected visual acuity was, there was accurate projection of rays in the right eye. There was no improvement on vision with pinhole. The intraocular pressure was normal in both the eyes. On further examination, the extraocular movements were full and free. And in the iris, there was a foreign body incarcerated in the inferonasal region near the pupillary border at 5 to 6 o'clock with sphincter tears. The pupil was sluggishly reacting and non-dilating. The lens, there was presence of PCIL with capsular phimosis. And on fundus examination, the media was hazy with discrete disc margins. The CDR was 0.3:1, and the retina showed a corrugated surface suggestive of RD. The details were not visible due to poor pupillary dilation. Rest of the findings were within normal limits in the left eye. B scan showed multiple dot echoes with single membranous echo in the vitreous with high reflectivity and moderate after movements. There was no CD. So based on these findings, the provisional diagnosis of right eye near total rhegmatogenous retinal detachment with iris foreign body with pseudophakia, status post-traumatic corneal tear repair was made, and the patient underwent right eye foreign body removal with synechulisis with PPV, endolaser and silicone oil injection under general anesthesia. So these are the intra-op findings. We removed a foreign body of approximately 10 mm in size. On post-operative day 1, the visual was hand movement close to face with accurate projection of rays. There was presence of air in the anterior segment with PCIL in situ. The posterior segment examination revealed a hazy media due to silicone oil filled globe. The retina was on, and the patient was started on topical medications with oral antibiotics, and strict prone positioning was advised. This is a picture of follow-up after 2 weeks. The vision had improved to 2/60. The anterior segment shows PCIL in situ, and the posterior segment showed on retina. So intraocular foreign bodies should be suspected in all cases of open globe injuries, and pre-op evaluation should include a focused history to determine time and mechanism of injury along with composition of the object. A careful examination with minimal pressure of the globe, minimal pressure applied to the globe is essential. Gentle B scan can be done by experienced personnel. CT scans aid in identifying the objects and further evaluating the globe or vital bones and planning surgery. The goal is to achieve best visual outcome possible by identifying and closing the entry and exit sites, reconstructing the eye if possible, and if possible, removal of the object. Ideally, the foreign body should be removed within 24 hours of the time of injury. However, in certain cases, we can wait if there are no signs of end-off and the vision is fine. So in such cases, we should do regular follow-up using vision, slit lamp examination, and serial ERGs. If the ERG shows deterioration, immediate surgical intervention with removal of object is required. And to decrease, there is a high incidence of endophthalmitis with intraocular foreign bodies. So to decrease the risk, topical antibiotics can be given, and intravitreal vanco or ceftazidime can be administered. So to conclude, position of intraocular foreign body depends upon the velocity and type of foreign body. As with metallic foreign body, high velocity tends to penetrate deeper. With non-metallic foreign body, there is low velocity and it does not penetrate as deep. The retained IOFBs can lead to peripheral vitreous traction and adhesions, which can be a reason for late onset RD, as in our case. The prognosis, whether intervention is early or delayed, depends upon the mode of injury, site of retained IOFB, and type of foreign body, besides other host factors. And even though it is rare, vegetative foreign bodies in the absence of infection can remain inert for years, and proper timely follow-up can prevent delayed onset complications. Thank you.
I think indeed we have to be very careful with intraocular foreign bodies, and just a footnote that he's from my institute, so we have really been removing all sorts of foreign bodies from inside the eye. And one very strange thing that we removed very recently was, you know, that a person had just gone, and that was a very long-lasting foreign body. We didn't even know that it was there, and then he had a chronic, inflammation. And then when we removed all the fibrosis around it, then inside it we found a foreign body. We just lasered the wound, and we decided to remove it, and we did.